Great. Good morning, everybody. Hope everybody can hear us. We're really excited to kick off the first Spot Coffee and Learn for 2023. Our community continues to grow, which is really exciting. So I'm going to go ahead and get started by sharing my screen. And just for everybody's knowledge, we are recording today's session because we are making a concerted effort to upload these videos and our presentations to YouTube. So for those who don't know, I'm Crystal Campbell. I'm one of the Planning and Oversight Committee members. And again, we're really excited. We have a very passionate, experienced simulationist with us this morning, who I'll go ahead and introduce. But we're really excited for Dr. Ashley Franklin as our morning presenter. So just to highlight for those, I know our community is growing. What is SPOT? So SPOT stands for the Simulation Professionals of Texas. I like to say we're all the same nerd who loves simulation, and we represent very different backgrounds. But our hope is, as we continue towards becoming a 503c, that we really are the premier professional organization that offers education, collaboration, networking, all of healthcare simulation, whether you're an educator, an ops specialist, a researcher, or administrator. So continue to spread the word. We appreciate it. That said, again, our group continues to grow, but we're so thankful for the leadership. On this slide, we're just highlighting our advisory board. It looks like a lot of them are joining this morning. So Jeremiah, Laura are on, and Ruben, yes, hi, thank you. Thank you for showing yourself on video. And then our morning, Ruben, and our Planning and Oversight Committee. I think most of us are here, and we're really excited for Bruce Williams to have just accepted a role with us. And so again, lots of opportunities to get involved. We encourage you all to consider it and reach out if you're interested. So that being said, I would like to go ahead and welcome our speaker this morning, and that is Dr. Ashley Franklin. A lot of you probably already know her, but she's an associate professor at Texas Christian University and serves as on the board of directors for the International Nursing Association for Clinical Simulation. She's taught pre-licensure nursing students for over 15 years, which is really impressive. And her research has been supported by the National League of Nursing, Sigma Theta Phi, and the International Nursing Honor Society, as well as the National Network of Libraries of Medicine. So I am so excited. She has a great presentation lined up for us today. So without further ado, I'd like to welcome you today, Dr. Ashley Franklin.
Good morning, and thank you, Crystal. I am so happy to meet you guys, and forgive me while I get my little PowerPoint in a little bit better position to share. I hope that if the technology goes wonky or you can't hear me, someone will stop along the way, because we never know. It's Friday. We never know what's going to happen. But it's been 3 years or so since I've spoken to this group. And so I'm happy to get to tell a little bit of my story today. Broadly, what I'm going to talk about is a program of research around multiple patient simulation, where in my mind, what that means is one student takes care of multiple patients at the same time. And I want to kind of tell that story of how it started, how it evolved, and then grew into multi-site and interprofessional opportunities. But before I do that, I just want to tell you a little bit about myself so you can understand some of the frames that I'm coming from. And I'm going to go way back around 20 years to kind of how I started. So I'm a nurse by training. I'm a TCU grad ×2 and a Texas native. And my clinical experience is in an ICU from the University of Pennsylvania Hospital in Philadelphia, where I took care of adult patients who had mostly needed life support for some reason, whether their kidneys weren't working or their lungs weren't working, or they needed lots of IV medications. So that's where I got started. In the process of working in an ICU there, I learned how to take care of organ donors, and then decided I really liked transplant. And so I came back to Texas and worked in organ transplant for the Baylor organization here in Fort Worth. It's called Baylor All Saints Medical Center, and did abdominal organ transplant for a few years with kidney, liver, pancreas recipients. And then in 2008, I came to work at TCU. The reason I tell you that background is both in my ICU work and in my organ transplant work. And of course, when I came to an academic setting, multitasking and taking care of multiple things at a time has been a constant in all of my work environments. And I'm betting that it's a constant in your work environment too. Just as people are logging on and telling the story of, hey, I have a visitor in my sim lab down the hall, so I may have to go. We're all used to this multitasking. So I came to work for TCU in the control room in 2008. I had a bachelor's degree in nursing, and I knew I liked technology. I had run dialysis machines at the bedside and plenty of IV pumps and ventilators and things like that. And so I wasn't afraid of technology and doing KVM switches and video angles and things. I was like, sure, I can do this. And I fell in love with it. I worked in the control room for about 6 months before I realized that this would probably be a really good fit long-term for me. And so I started a master's degree. And I finished that master's degree in 2010. And at that time at TCU in the pre-licensure nursing department, we were starting to do multiple patient sim in teaching. And there are colleagues on this call who started that 12 years ago with me. And so it's so fun to see where it's gone. The origin for us of having one student take care of, usually it was 3 patients in simulation, was we wanted to give them a chance to practice taking care of more than one patient, to keep track of their information, and to develop those processes of patient care to flow from one patient to the next. We were interested in hand hygiene habits. We were interested in communication and could they keep more than one patient straight in their mind. We were interested in safety around medication administration, particularly. And then when you deal with multitasking, there's some inherent things like time management and priority setting that are required. And so my program of research started in a teaching experience. And I was just really interested in trying to figure out why some of the learners who did our multiple patient simulation did it really well. And then some of them it was really challenging for. And at that time, all of our learners were seniors in college. They had had 4 semesters of clinical experiences in primarily acute care hospitals around DFW. They had the same coursework, the same teachers. And I was interested in why this was so challenging for some of them. So I think finding that why is a tip I would offer to everyone, because that's what's going to keep you going. And it's kept me going in this stream of research for 12 years so far. After working in a multiple patient sim environment in teaching, I started a Ph.D. in 2011 at Oregon Health and Science University. So I told you I was a Texas native. My family moved out to Portland, Oregon for 3 years for me to go to graduate school. And I learned so much from getting to teach in primarily the undergraduate nursing program at the university while I was a student there. I learned how to work with actors there, which was something brand new for me. I learned a lot about a diverse patient population that I hadn't experienced before because I had lived in Texas and I had lived on the East Coast, but never out West. The research question I went into my PhD with was, why do some students do well in this multiple patient simulation experience and some don't? So over the course of 3 years, every course I took and the papers I wrote was about some element of this multiple patient simulation experience. And by the time I was ready for dissertation, I decided that I wanted to test simulation preparation interventions and see if I could make a difference in learner performance if I help prepare them with either reading materials, which is kind of how most people do simulation preparation. And then I had 2 interventions. One was a voiceover PowerPoint, which 10 years ago, that was kind of new and fun. And the other was an expert modeling video. And so I did a pilot randomized control trial in my dissertation with these 3 groups of simulation preparation activities. And we had a group of around 20 or so senior nursing students who were ready for their capstone clinical come in at the beginning, and they did a multiple patient simulation experience, kind of cold. They didn't get any prep that first time. And then we gave them one of the 3 simulation preparation interventions, and they used that once a week for 4 weeks in a row. And then after 4 weeks, we brought them back and had them do it again. And so that was kind of my first research experience where I got to ask the research question and organize the team. And it was all built on this core teaching experience I had from TCU that started in 2010. When I finished my PhD in 2014, I moved back to Texas really happily because my family is here, and Texas feels like home, and I felt like I knew lots of the resources. I had a grant that was funded from the National League for Nursing that allowed me to do a replication of my dissertation with 2 sites. And we did that project around 2016. One site was in Texas at TCU. That was when our simulation lab was opening for the first time. So that was kind of a way for us to baptize our lab. And then I continued with the location in Oregon where I collected dissertation data. But that jump for me to have a multi-site project was a big jump and important in the steps along my research career. And I want to tell you how that's kind of unfolded now. After 2016, I continued this multiple patient interest and found some interprofessional colleagues, and we published an interprofessional paper around this same multiple patient simulation research project in 2020. And I will tell you that at the end of my slides, I have a QR code link to my Google Scholar page. So if you're interested in pulling those papers or reading bits of them to see how that all evolved over time, I'll share that slide. So with that as a background, I want to tell you a bit about this multi-patient scenario that was kind of the core of this stream of research for me. So imagine that you are a nurse, maybe a newly licensed nurse, and change of shift is a really troublesome, kind of overwhelming time because there's so many extra people in the unit and you're getting to know new patients and just figuring out where stuff is and how your 12 hours is going to go. So our scenario was set at change of shift. And we do a 45-minute scenario where one learner takes care of 3 patients at the same time. And I've always done this in research purposes with mannequin patients. And the reason is I can control them really well. And so no one can question that a different cue or a different actor that day impacted results. So I do like mannequins for research purposes. These patients are mostly stable. Think like patients who are maybe on a telemetry unit. We use diagnosis of prevalence, which I do think helped me get funded because there are lots of people who have diabetes. And so any research around helping us take care of patients with diabetes is pretty glitzy and fundable. So one patient had stable diabetes. One patient had a bit of respiratory distress. They needed oxygen. They needed someone to titrate their oxygen or give them rescue medicines like maybe a breathing treatment or some furosemide so they could breathe a little bit better. And then the third patient had some version of recurrent chest pain. So with our setup of change of shift and just 45 minutes, our objectives for our learners were to do an assessment, which to me means they're doing a safety assessment, and then probably a focused physical assessment. They needed to decide which patient they needed to see first, start giving medications, and practice delegation to an unlicensed personnel. In terms of our operations, one learner went through this activity at a time, and that's how we've maintained it for the 12 or so years we've been doing this. So per learner, we had one operations specialist in the control room who served as the voice of all three patients, controlled our AV system. So if we needed to follow a learner around the room, they could track them with the cameras. And they were using pre-programmed scenarios. So operating the mannequin software wasn't super challenging for them. I'll tell you that one of the strengths for us of doing this one learner at a time is it only takes one operations person, because one learner can't be in multiple places. So that was like a logistical decision we made and have stuck with it. So there's one operations person who's in our control room. There's a faculty member who their primary role is documenting performance. We have a rating tool we use. It's called the Creighton Simulation Evaluation Instrument. And so the faculty member is solely focused on evaluating that learner. And they're the one who does debriefing after the simulation. So they're able to take notes and, plan out their debriefing. And then that one learner takes care of these three patients, and they take up 2 patient rooms. So historically, we've had like 2 male patients that share a room and 1 female patient that might be down the hall, or vice versa, 2 females that share a room and 1 male that might be down the hall. In our lab at TCU, we have an 8-bed acute care simulation lab, and we run 2 learners concurrently in this activity. One is literally on each side of the hallway, but they're running on the same schedule. So we use like 2 operations specialists, 2 faculty members, and 4 patient rooms at a time. And we've been doing this model with full cohorts of nursing students, around 80 students in a cohort, for about 4 years now. So it's, I think, a fairly sustainable model. In terms of outcomes that we're interested in measuring, I told you that we had a score sheet that our faculty members were primarily using, and that's to score behavioral performance. I know competency is a huge buzzword in medicine, nursing, pharmacy, social work, all of our disciplines. And so behavioral performance was the core outcome that I started with, and it's the kind of the core that we have stuck with over these 12 years. We use a tool called the Creighton Competency Evaluation Instrument. It was also known as Creighton Simulation Evaluation Instrument. It was the behavioral tool used in the seminal National Council of State Boards of Nursing study that was published in 2014, and it was used before then. So it's one of the more popular, considered very reliable instruments for pre-licensure nursing. One of the strengths of that, I'll tell you, is it's a dichotomous checklist. So we are scoring behaviors, either they are present or they are not present. And that helps us a lot in terms of having reliable evidence. So we're sure that our outcomes are actually outcomes of the study. So behavior performance is where I've always been really interested. As time has gone along, I also became interested in some would say like personality traits or characteristics that impact learning. Early on, I was interested in self-efficacy. That kind of faded, I'll tell you, after the first 4 or 5 years. But the first couple of publications that I had around multiple patient simulation used self-efficacy as an outcome variable. I became interested in someone's time perspective and whether they were a forward-thinking kind of a person or they thought more about what had happened in their past. And so I measured balanced time perspective with a series of surveys to try and see if that impacted multitasking behaviors. And it didn't really, but it was a good question to ask. And then I became interested in cognitive load, which definitely is part of learning theories. Cognitive load, some individuals call mental workload. You might think of this as stress that your learners experience, whether it's stress that they experience relate to feeling time pressure in a simulation, or having to multitask in a simulation, or for some people, just the physical stress of doing whatever the task is at hand. And so I'm going to talk a little bit more about how this stream of research has evolved into more cognitive load research. But across these first 3 iterations that I told you about, my dissertation being the pilot in 2014, and then a multi-site study in 2016, and then an interprofessional study in 2020, all with the same structure and the same 3 patients. Our main conclusion was that learners just need more time and experience in multiple patient simulation. And you know what, conceptually, that made sense to me and to interprofessional colleagues too, because in nursing school, our learners don't get a chance to take care of multiple patients at the same time in clinical and be the only one that is responsible for the care of those 3 patients. And so that's one of the strengths that we can provide in simulation, both in a safe place because a patient can't get hurt, and in a safe, like, educational structure, because we're giving a chance for our learners to stretch beyond their comfort zone and try these higher order thinking skills like priority setting and delegation. At the same time, they're doing basic skills, hand hygiene and medication administration and things like that. So I want to talk to you a little bit about research design, because that is honestly a little overwhelming, I'll admit. When I'm planning a research study, I'm so thankful to have a statistician usually next to me that I can say, hey, does this make sense? And over time, I've developed great relationships with statisticians. But it's really important to me that the research design I picked matched the aims and the research question that I was asking. And I'm sure it's not a surprise to you for me to tell my clinical story that I'm an ICU nurse, and then I like multitasking. I'm a really quantitative-minded researcher. So I ask mostly questions that I can see numbers and make graphs to show impacts of my learning. So I told you I've done a few randomized control trials around the effect of various simulation preparation interventions. And what's interesting is some people would consider that design as more rigorous, or like the ultimate, I'm going to work towards doing a randomized control trial. And my experience has kind of been the flip. I did a randomized control trial first, and then I realized that my area of research wasn't as simple or cut and dry as I had thought it would be. And so I needed to back up. And so when I backed up, I only had one group in that 2020 interprofessional study that I described. We weren't doing an intervention at all. Instead, we had one big group of around 225 nursing students. And we were asking them to do this multiple patient simulation. They still did it 2 times, but we were trying to see if anything about their time preferences or multitasking preferences or demographic background impacted the way they performed, like behaviorally, or the way they felt stress when they scored their cognitive load. So I guess I want to tell you that this is a great example of how you don't have to do a randomized control trial for everything. I started in a randomized control trial and then I backed up because I was like, I want to ask a different type of question. And so in this example, we had one group of 220-ish nursing students, and they did this multiple patient simulation 2 times. We had them fill out surveys to represent their multitasking, cognitive load, temporal differences, and we still scored their behavioral performance. you can tell from the stories I've told you so far that this is a journey. And sometimes I can't control the journey. And that's exciting and kind of invigorating, and also makes the ICU nurse in me really nervous because I can't control it. But I think a lot of doing educational research and simulation is following the path. And that's why I picked this messy little diagram to be in the middle. The next thing I want to talk about is multi-site versions of simulation research. Multi-site research has a lot of strengths. The most logical strength people think of first is that your results are more generalizable because you have a bigger sample, and hopefully you have a more diverse sample. So earlier this week, I was talking with Ruben, who's on the leadership team for SPOT, and he and I remembered that we had met at SPOT 3 or 4 years ago. But Ruben's from South Texas and I'm from DFW. So you can imagine it'd be great for us to collaborate because there's some regional differences in where we live and probably how we deliver healthcare. And so it would be fun to get to collaborate. When I think about multi-site research, there's a group of decisions that have to be made for like the host site, and then for the secondary sites too. And so that's what I want to kind of describe to you. So let's say TCU is the host site, which makes fairly logical sense because that's where I work every day. So it's a little easier for me to do some of the tasks to get a research study started because I'm in that environment. So I spent a lot of time in the first year of planning this stream of research just validating my scripts. And what that meant was writing learning objectives and planning out cues that we would deliver to help our learners achieve those objectives, planning all the logistics and the scenario programming for what the mannequins were needing to do at a certain time. The supplies around like what medications do I have to have ready? What equipment do I need in my room? It's just like scenario design and following the healthcare simulation standards of best practice. So that's always where I start, is with the scenario. The next kind of cognitive activity I had to do was look at the evaluation tool and figure out what behaviors I was expecting for each of these patients. And what was really important to me was that I could map complexity to know that I was comparing apples to apples. And so I've described to you that I always did this multiple patient stream of research where my learners were completing this scenario 2 times. And so using those diagnoses of prevalence, we had a respiratory patient, a diabetic patient, and a cardiac patient, both in their first scenario and their second. I didn't want the patients to be exactly the same because then my critique could be, oh, well, they just remembered what they did the first time and they did it again the second time. And so it's just memorization. And so my trick was like my first version of a respiratory patient was male. My second version was female. The first version might have had COPD or emphysema and had respiratory distress because of that. The second version had liver cancer and fluid building up in her abdomen and lungs that made her have respiratory distress. But in both of those examples, I was expecting the learners to listen to breath sounds, to ask subjective and objective questions about how their breathing was feeling, to ask about a cough, for example, if anything was coming up, and to titrate oxygen. And so even though the patient's story was different, I knew that the complexity of behaviors I was expecting the learners to demonstrate was very similar. So it was important to me to make sure I was comparing apples to apples. After I kind of went through that mapping process, I had to build consensus with my raters to articulate that in our evaluation tool. And so that takes some process, but you can kind of build consensus around your evaluation tool and train your raters at the same time, especially if you have some videos of learners doing this scenario. And so I was fortunate to have some videos that we had used in teaching of learners doing this scenario. And we chose some learners who like had high levels of ability and then those who had low levels of ability. And we used those to train our raters. And after all those kind of logistics are done, you can kind of start thinking about protocols for day-to-day operations, how you're going to set up your rooms, how you're going to switch over between cases, how many cases do you think you can do in a day, and all those types of logistics. And I'll tell you, before I left the host site, I started garnering administrative support. First from my campus at TCU, which meant I had to make sure and have approval from the director of our simulation center to use the space, and some of the resources that would have to be like in kind. So our sim operations staff are like supplies, disposable supplies for oxygen equipment and medication administration and beds and pillows and IV pumps and all that stuff we would need. And then I also had to get administrative support. On my campus, we have a director of research that I had to go through, and then like my associate dean in our academic setting. So I think those are kind of all host site type tasks, and that's where I start multi-patient simulation research. And then if I go back to the example of, let's say, Ruben and I collaborating, and we were thinking about Ruben's site as a secondary site, Ruben and I would have to start considering, what is the academic experience of my learners in my department compared to his learners? And what that means to me is, how much time have they spent in the simulation lab before? Because that's going to impact the way I can measure outcomes of simulation. How much time have they spent maybe in a clinical setting before? And have they both had the content in terms of curriculum that matches the patients that I'm interested in testing in this scenario? Then we have to kind of talk calendar, and that's hard. It's hard for any version of multi-site or interprofessional experiences, but it's important when you're doing multi-site research, particularly, that you know the structure of the calendar is similar. So if you're doing a 2 scenario experience and they're separated by 4 weeks, it has to be the same 2 scenario experience separated by 4 weeks on all of your campuses. And so just planning that is important. I'll tell you, when we did the multi-site study that was published in 2016, we had our raters get on an airplane and travel to the other site. And so when we were planning calendar, it meant that we did the Texas site in February, the Oregon site in March, the Texas site again in April, the Oregon site again in May. And so that was a part of our calendar planning. But honestly, it was a strength of our design that we had this same 2 raters scoring all of the participants. That way, no one could kind of accuse us of having one rater that scored really high. And so that worked for us. After all these logistics are kind of worked out, it's important to get IRB approval. I've sat on the IRB at TCU for a while, and typically the way IRB approval works is whoever the primary host site is gets approval, and then the secondary sites endorse it. So I could show my approval from the TCU IRB and all of that paperwork to Ruben's campus, for example, and then his campus might endorse it. That's the way most multi-site projects are working post 2018. Other differences between sites that you have to consider that are really specific to simulation are how your sim space is set up. How many patient beds do you have in a room, for example? What does your medication room look like? Is there a phone in each of the rooms? Do learners use the electronic health record in the same way? What's the control room space? Is it like my control room at TCU right now? There are no one-way glass windows. We use a computer to watch all of our camera angles, and we're 100 yards away from any of the learners. But it would be different if one site had that distant control room and the other site was literally attached and only used a one-way glass, and they didn't use an AV system at all. So all these things you kind of have to talk about. One of the strengths that really helped us was having some preset camera angles in our AV system. So we knew if we were wanting to watch the way our students interacted with checking safety behaviors at the beginning of the scenario, we could see if they were looking at the oxygen flow meter, for example. We could see if they were looking at like the wristband on the patient's arm. So we picked what our preset angles needed to be. And then we had to compare mannequin capabilities. Even if you don't necessarily have the same brand of mannequin, I don't think that's the problem. But you want to make sure all the mannequins have lung sounds, for example, and chest rise and fall. That way you can know that it's not a variation in mannequin that's interfering with your data. I believe this is the last slide about multi-site research that I wanted to share. But I wanted to kind of zoom out a bit and just talk about how multi-site research requires a lot of communication across sites. In our context, because this was done over about 4 months, and in 2 schools of nursing that I knew both of them pretty well, we were able to have monthly team meetings, and I was kind of the team leader for both campuses. If this was a multi-site project with 10 sites, you would want instead to have like 1 champion per site who coordinated with a central team leader. But in general, we had monthly team meetings probably for a year leading up to this data collection. And in those team meetings, a lot of our conversation was focused on logistics. Like, hey, how do you do medication administration at your site? And can you take some pictures of what this looks like so we can try and figure out those logistics? We did spend probably 40% of our time in those team meetings on radar training. So I mentioned to you, we had some videos of students doing this scenario from a teaching atmosphere. And we just shared those. This was pre-Zoom. We used Adobe Connect, I think, but we would share videos online, and we each had copies of our rating tool. And so we would watch a video and then rate, and then we had a discussion about how we rated. But all those things need to happen in the months leading up to this research. And then when you're actually in data collection phase, it's super helpful to have one person who's in charge of all the communication to the learners. And my experience has been that those learners needed weekly email reminders of what was going on, whether it was their calendar that you were sharing first, or when we were doing intervention work and we were expecting them to log in and either view an expert modeling video or a voice over PowerPoint every week. We sent them an email every week that said, don't forget, you're supposed to do this for an hour. And so that was a super important thing that helped me know that my learners who were participating in this study all were getting the same dose of whatever intervention I was trying to do, which was a strength of our protocol. I wanted to say that no matter what simulation research you're doing, you're going to feel like you're nudging it down a path, kind of like bumper bowling. I don't have complete control over this, I'll admit, but I literally think of how I get to touch it a little on the right, like a bumper, and then it rolls some, and then I touch it a little on the left, and it goes a little more. And my hope is that eventually I get down to the pins at the end of the bowling alley and have a publishable product and hopefully collaborations with some new people and a different version of my research question that kind of stimulates my next study. So the last part I wanted to talk about is just the interprofessional collaboration part. And I think this is a really cool example of leveraging your network. And I told you my clinical background is in nursing, and then my academic experience is teaching in a nursing program. And so when you look at the top part of this slide, what I want you to see is that my background in nursing, early collaborators I had with who were physicians and our statistician, we could all get our head around this behavioral performance. And that's what we work towards as the main outcome variable in this multiple patient stream of research. And then I met a colleague who's an organizational psychologist. She taught in our business school, and she had done healthcare simulation research in a hospital setting in Boston before she moved to Texas. And so she just came over to see our lab one day, and thankfully a colleague introduced us, and she was like, well, tell me what you're doing. And I told her about this multiple patient sim thing, and she said, you know, what would be so neat is to see how their multitasking preferences impact their behavioral performance. And so she got me interested in multitasking preferences and in cognitive load. She's a teams researcher. And so we did a secondary study with teams of 3 who were actually only taking care of one patient. But she helped me ask a different research question related to teams because that's what she was interested in. And then she helped me also learn about psychological safety measures that we could look at to see if our learners felt safe in this simulation I was putting in. Because if they didn't feel safe, then that might be why their behavioral performance wasn't very good. So I hope that you can see just leveraging my network helped me have more variables that I was interested in. And that's kind of how my program has unfolded. Meaning that organizational psychologist also helped open my eyes to new funding sources. She had a former Ph.D. student who was applying for funding from the U.S. Army Research Institute, and I got to collaborate on a project with them. And that was pretty cool because it was an international interprofessional collaboration funded by the federal government, which was a big deal for educational researchers. In that project, we put together groups of 3 who were taking care of a pretty acute patient in an emergency department setting. And in that study, we tested an intervention around leadership and followership behaviors. And so we used a voice over PowerPoint to train team leaders and then to train team followers. And then we put them into a situation with an ER patient that was completely blind to them. No one knew this ER patient. And we scored like behaviors, how their leadership and followership came out while their patient was acute. Another theme that continued in that particular project was about cognitive load. Excuse the tickle in my throat. So this is the very last thing I wanted to share with you, and it's just about kind of current research interest. I learned from this colleague in organizational psychology about cognitive load theory. And this is where I think my program of research is going. But remember that bumper bowling example I gave you, like I can't control this. But my research team at TCU, and there are several colleagues on this call, this is a project that a lot of people are involved in. This is not a me thing, this is an us thing. But we are moving towards a line of cognitive load research. We're looking at cognitive load across simulation roles. So you can think of that as like team leader versus team follower, or in the nursing context, we think team leader versus like the nurse who's responsible for giving medicines, or the nurse who's responsible just for assessment and teaching. I have a real interest in looking at our learners' cognitive load while they're administering medications, and doing that in scenarios of increasing complexity. So our learners give medicines for 4 semesters in nursing school, and I want to know, are they more stressed out over time when this patient is sicker, or are they more stressed out in the beginning when they're just learning it for the first time? Like, I just want to know. And then another kind of branch of where I think we're going is trying to define what does it look like when a learner in simulation is overloaded cognitively. We were fortunate to get some equipment last March, and we have these eye tracking glasses from a company called Toby, and they measure pupil size, and they follow your patient's eyes as they look around an environment. So these are like head-mounted display, and where you can put them on a learner who's in simulation, and have them do simulation, and we can see where they're looking. The glasses help us track how quickly they're looking around the room and what they're fixating on. And then theoretically, there are lots of explanations about, oh, this means they're overloaded, or this means they're not. And so I think this is where we're going. So we're using these Toby glasses, and then we'll continue to use subjective cognitive load surveys, and hopefully maybe be able to explain how cognitive load accounts for the difference in behavioral performance in our simulations. So I think I've gotten kind of to the end of time. I would love to have a conversation or answer any questions you guys have. This QR code link is to my Google Scholar page, and there are several publications that I referenced that are listed there. I hoped that was an easier way to share things than just a reference page. But with that, I'm happy to answer any questions that you guys have or want to talk about.
Outstanding. Thank you so much, Dr. Franklin. That was very informative and exciting to see all of your research and your hard work. Definitely would love to hear from the rest of the group. We have a big group on today. Any questions you may have, you can either drop your questions in the chat or simply raise your hand and then unmute yourself.
Hey, this is Erica from UTA. I'm also on the Oversight Planning Committee with SPOT. There is a question in the chat if we want to start there. So Kat Kreis, who also works here with me at UTA, is interested in eye tracking research. And that's something that she wants to do going into the future. Do you have any more that you could talk about that? Is that something that you've also been interested in, and maybe even consider multi-site if that's something that she wants to do as well?
Yeah. So Kat, I would tell you come over to TCU and play. We only have had this equipment for about 10 months on campus. And I'll tell you that a colleague named Jeffrey Room, who I believe has since retired, but he was a CRNA from University of Miami, was the one I learned about this from. And I remember coming home from an IMSH conference in 2019, and it was in San Antonio. So we were like driving up I-35, and for 3 hours, I talked about eye tracking glasses. I was like, this is so cool. The multi-site limitations with it is the equipment, because the equipment's fairly expensive. And so it comes with its own little suitcase to travel around. And it's just that you can have one learner wear these glasses at one time. And then the risk of injury to the glasses, you know, we're very much babying these glasses at this point, because we've only had them for 10 months. But I would love, if Kat, you want to come over, or anybody else, maybe we could have an eye tracking fun afternoon. We've used them we had to do training, I'll tell you, like the vendor gave us several hours worth of training. And then we've done like an eye tracking journal club, probably for about 7 or 8 months, just to learn from other disciplines. There's a lot of eye tracking research that comes out of psychology, and it's growing in healthcare disciplines. But we've done journal club to kind of educate ourselves about what's published. We have put the glasses on learners who are pretty new in simulation and walked through a couple of scenarios with them. And we're hoping to start our first eye tracking study in the fall. And our proposal, honestly, with that is only with 25 learners. And that's what Dr. Grun from Miami kind of advised me to do, because these glasses generate so much data that as we're learning how to do them, it's just very overwhelming. So we're trying to be smart and design a study that we can actually finish, but we will get to multi-site. And Kat, I'm glad to know you're interested, because UTA is 20 miles away. So come play.
I don't. Oh, sorry. You can go, Crystal.
No, I was just going to say, thanks so much. And Erica, are there other questions?
I don't think I see any more questions from the chat. I've been writing down some questions as you were talking, Dr. Franklin. What's your mentorship on getting past what I'm going to call publication intimidation, right? So those very first few times where you are trying to submit that, there's going to be that fear of it's going to get returned back to you. There's going to have to be corrections made, but I've now slowly realized that's a very normal process, but it's still very intimidating.
Yeah. So publication intimidation, or if you Googled imposter syndrome, that's what you're talking about. Realizing like, oh, I don't know if I can do this. And what you said, Erica, about papers are going to come back with comments and edits that needs to be made. You're right. That is totally normal. I've never had a paper that I haven't gotten 2 pages of comments from a reviewer. As far as mentorship, I would say it's helpful to have someone has more writing experience be your buddy while you're trying to go through, because there is just kind of a format to writing a research paper or even a conceptual paper that someone who's written before can help you with. I think it's also a great idea to have somebody like pre-read it before you submit it, because that pre-reader may help you with some of the low-hanging fruit comments that you'll get from a reviewer, and it's a little less intimidating to get them in track changes from a reader than, in a portal from a journal where you have to respond publicly. But I think it's part of the practice. I feel like I am to the point now that I really enjoy writing. And it's taken me 12 years to get there, I'll say. But I do enjoy, like I spent a lot of my Christmas break writing, I was like, this is kind of fun. I like to figure out how I can communicate an idea in 2 sentences instead of 2 pages. And that's a challenge. So I think, just like I spoke earlier about journal clubs, like having a writing accountability partner has been really successful for me. And a few years ago, my writing accountability partner, she did biobehavioral research with cancer patients who were adolescents, like not in my area at all, but we read each other's paragraphs and helped with, sentence structure and topic sentences in a paragraph and active voice and all of those things. And both of us had publications at the end of it. So those are my 3 top pieces of advice. Get a writing buddy, have somebody pre-read it before, and write with someone who has a little more writing experience than you do.
So I do see another question in the chat now. This is Kyle Martin. He's also here at UTA. He's brand new. He just started on Wednesday of this week. He is interested to know what other tech pieces you are excited about going into the future for future implementations.
Cool. Welcome, Kyle. It's neat that you're here your first week. So I think when you say tech pieces, I think you're talking about like eye tracking glasses that I spoke of. I'll tell you something else we're interested in is biometrics. And we didn't invent this. Again, I was so excited in 2019. And the first presentation I heard with these eye tracking glasses, they also had vests that participants wore like under their scrubs. And they kept track of heart rate variability, respiratory rate. They had a pedometer built into them, and so you could see how many steps people were taking. I've seen people that use like actigraphy watches to get the same heart rate variability. But particularly because in this cognitive load stream of research where we think we're going next, you can't reach into somebody's brain and figure out what's going on. All these indirect like proxy measures, the glasses, the heart rate variability. I really like that. And I told you, I'm an ICU nurse, like I'm fairly techie. And so all that makes me excited, but that's next on our list. We will get some of these vests. The vendor is called Hexoskin. And that's their kind of moderately priced product. They have something else called Astroskin, which is a little crazy, but both measure biometrics. And so I'm really into that kind of thing too.
Yeah, I think that would be exciting, that aspect of it. I do think that there's a lot of pieces that could easily play a role into some of the outcomes, hormone levels, perhaps. There's also that struggle of, even if you do everything the best that you can, people are still going to be anxious or still behave a certain way going through an activity, which is also interesting to think about or to do research on as well.
Yeah. Well, and I would follow that up with, you're right, like hormone levels. There's a colleague that has a lab down the hall from me that does cortisol. I think one of the benefits of doing like the physiologic measures plus the surveys is you can kind of see like, oh, physiologically, hey, their heart rate's up. But then my survey can tell me 5 reasons why their heart rate might be up. So I think we have to triangulate is the research word to get lots of sources of data so we can try and postulate about why the heart rate's up, for example.
I could ask questions all day because I do have one more, but is there anybody else on here that has a question that they want to drop into the chat? Or you can definitely unmute yourself and ask the question out loud if you'd like.
Yeah, I'll jump in and ask a question. I'm a past, dare I say, co-author and believer in Ashley Franklin. I was going to just ask, one of the questions you had that came up is you were talking about when you're doing simulation research, that working with mannequins is a way to help, sounds like an immense level with variability that can come up because there's certain things. For someone who's new to simulation research, just kind of learning from you today, what's another way, what's another example of like variability that comes up that is something that you're trying to address in a meaningful way to have consistency in your research?
Yeah. So T, thank you for your question. So everyone knows T's a social worker and we've published 4 or so times together and spoke together, I think, at a spot meeting over at Crystal's Sim Center a few years ago. And you know what, I'll tell you, T, I know, knowing your social work background, mannequins are really hard to think about needing to use. And so it makes sense to me. Like I just spoke for a while about how I'm interested in learners' behavioral performance. So I use a mannequin. If you're not interested in behavioral performance, actors probably make more sense. And I know that's where the bulk of your research has been. If I had to comment on variability, one thing I would say that would be a strength to add rigor to a program of research that involve actors is looking at the degree of sameness between 2 actors that are portraying the same case. And can you train a group of actors? Let's say you're doing an OSCE and you have 10 rooms going at the same time. Can you train those actors so they are 90% the same in the way they're delivering both like verbal and nonverbal cues to your learner? Because it's when people go off script, and even if it's their best intention that they're going off script for a decent reason, while that makes sense in a learning environment, when you put it in research, it really muddies the water. And so you can't know if like the simulation experience is what helped that learner achieve this competency of where you're going, or if it was some variation that that actor did. So I think the key is knowing that you're same. And you know, in a behavioral performance setting, we measure inter-rater reliability. In an actor OSCE setting, it's almost like you need to measure inter-actor reliability, as they're both, all 10 of them are portraying this role concurrently, you know, in a giant hallway for an OSCE.
I was going to say thank you. I appreciate that answer. This presentation has been so inspiring to hear. Thank you so much.
Thank you, T. And yes, thank you, Dr. Franklin. This has been outstanding. Not only have we had record attendance, I think this topic is so meaningful to all of us on the call. And I just wanted to first thank you again to Dr. Franklin. I learned so much, and I'm sure the rest of you did as well. I have one final slide from the SPOT group, and I just want to highlight, because I think there's a huge opportunity to continue this conversation even beyond today. We could probably stay here for another hour. But if you haven't joined LinkedIn or Facebook, please do. I think a community of learning is how we all grow. And like Dr. Franklin said, even doing multi-site collaborations, whether it's with Ruben in Southern Texas or even across states. So please use our Facebook and our LinkedIn to start this conversation, and we can consider other opportunities opportunities. I mentioned earlier too, there's lots of chances to get involved as SPOT continues to grow. Our mission is to be the full state of Texas, so we're really looking to do more outreach as well. So if you know people and want them to get involved, let us know about that. I'd also love to just close out again, thanking Dr. Franklin and thanking everyone for joining. So I hope everybody has a wonderful Friday. Happy Valentine's Day next week.
Yay.
Yay. Thanks, everybody. Thank you.